ever take care of babies? And are you a little bit confused about where we've landed with the jaundice and the hyperbilirubinemia guidelines, and when we should be starting phototherapy and which babies we're most concerned about? Well, you're in the right place. I'm Dr. Tala, and I've been a neonatologist for over 15 years now. And today we're going to cover the AAP, or the American Academy of Pediatrics guidelines, the most recent update that they put out in 2022 on the management of infants with hyperbilirubinemia. I'm even wearing yellow, so you really remember it. As a quick reminder, we did film 4 videos on jaundice a couple of years ago. So if you're confused about the difference between direct and indirect hyperbilirubinemia, or what the difference is between breastfeeding jaundice and breast milk jaundice, or what is a hemolytic jaundice, hemolytic anemia, what is a direct Coombs, then go back as a revision and check all of those out before we go into kind of like the clinically applicable steps in this video. So these AAP guidelines cover pretty much everything that you need to know to be able to take care of babies above 35 weeks in the NICU. And just as a reminder, I know you know all of this, but the main reason that we care about hyperbilirubinemia or jaundice is to prevent, yes, kernicterus. We don't want any of these babies getting kernicterus. If you can't remember what that means, go back and check the previous videos we filmed. This policy covers 4 or really 5 main segments, but we're going to cover 4. 1, the prevention of hyperbilirubinemia. 2, its assessment and monitoring. 3, treatment. And 4, post-discharge follow-up. The other great thing about this paper is it lists 25 key action statements, or KAS is the acronym that they use, which are all statements that we can apply clinically for our babies. So we'll be covering those as well. Right, let's start with 1, the prevention of hyperbilirubinemia. As you all know, this starts when the mothers are actually pregnant. We need to know if the babies are set up for hemolysis. If you remember, the mothers that we worry the most about are the mothers that are type O blood type, or Rh negative. Also, it's possible that the mother has antibodies to other red blood cell antigens if she had a blood transfusion in the past, or if she had previous pregnancies. If you can't remember why, go watch the previous videos. So the first key action statement is, if the mother's antibody test is unknown or positive, which means that she does have little antibodies floating around her system that may be attacking antigens on red blood cells, then we should be getting the baby's blood type as well as a direct antiglobulin test on the baby. So basically a Coombs on the baby. And that will actually check whether there are antibodies sticking to the baby's red blood cells and causing them to hemolyze. So realize this has changed in the past few years. We used to get baby's blood types on everybody. Now we'll only get the baby's blood type and the Coombs if the mother is Rh negative, or if the mother has a positive antibody test. If the mother is O positive, then you have a choice. You can either send the baby's blood type and Coombs immediately, or you can just follow the bilirubin levels and only end up sending the baby's blood type if the bilirubin level is getting higher. The second aspect of prevention is providing good feeding support. We know that breastfeeding is highly correlated with high bilirubin levels. So it's very important that if mothers are breastfeeding, that they are provided with adequate support, whether it's lactation support or whether it's encouragement from the postpartum nurses and everybody else taking care of the mother. Mothers should be breastfeeding at least 8 times in a 24-hour period, so on average Q3 hours. The second key action statement covers whether other forms of supplementation should be used as a way to prevent hyperbilirubinemia. And in KAS 2, they quite clearly say that oral supplementation with either water or with a dextrose solution should never be used in the prevention of hyperbilirubinemia. Whether you end up supplementing with donor breast milk or formula is a decision that can be made with the team, with the parents. Now let's talk about the assessment and the monitoring of hyperbilirubinemia. What the AAP really emphasize in this section is that we should identify and be aware of babies that are especially at high risk of developing hyperbilirubinemia. They list the risk factors for developing jaundice in table 1 of the paper, and they're exactly what you would expect. So prematurity, hemolysis, need for phototherapy in the first 24 hours of life, exclusive breastfeeding, cephalahematomas, LGA, IDM babies. What we all know. So they also spent a couple of paragraphs talking about G6PD deficiency and the importance of recognizing whether a baby has it or not. So remember, G6PD deficiency, and we discussed this in the previous videos, is a genetic variant of red blood cell metabolism. So if the infants are lacking that enzyme, then the red blood cells are more likely to hemolyze. So obviously it's a non-immune hemolysis. It is inherited in an X-linked manner. So remember, G6PDX. I don't know, that might help. So obviously it's more common in males. It's also more common in African, Middle Eastern, and Southeastern Asian communities. And about 13% of African American males have G6PD deficiency. So obviously a lot of babies in the US as well. So what the paper really emphasizes is that if you have a bilirubin that's rising rapidly and it looks like it's hemolytic, so you have a high reticulocyte count, but it's not immune, then you should definitely be thinking about G6PD deficiency, especially if it's a boy. These babies are at higher risk of developing kernicterus. So obviously a big part of assessment and monitoring is to actually identify which babies you have to start phototherapy on. So that brings us to key action statement number 3. And key action statement 3 is that the total serum bilirubin levels should guide whether you start phototherapy or not. So whether you start phototherapy or not, or eventually whether you escalate care, really depends on 3 different things. Number 1, the hour-specific total serum bilirubin level. So how many hours old the baby is when that bilirubin level is checked. 2, the gestational age of the baby. And 3, whether the baby has any potential neurotoxic risk factors. The neurotoxicity risk factors are all listed out in table 2 of the paper. And again, they're exactly what you would imagine them to be. So a gestational age of less than 38 weeks, albumin of less than 3 grams per deciliter. And remember, this is because bilirubin is normally bound to albumin. So if the albumin is low, then you'll have more free bilirubin that can cross the blood-brain barrier into the brain. So then a hemolytic cause is another risk factor. So isoimmune or, for example, G6PD deficiency. Also sepsis or significant clinical instability within the last 24 hours. And that's kind of like a clinician decision. They didn't really provide a pH or needing pressors or whatever. But really that's under the understanding that if the baby is unstable, then there's more likely to be a breach in the blood-brain barrier and you're more likely to end up with kernicterus if the baby's unstable. Now let's cover the visual diagnosis. As you all probably know, we're not very good at looking at babies and seeing how yellow they are and then estimating the bilirubin levels. It's not an accurate way of deciding whether a baby needs phototherapy or not. The exception to that is if you look at a baby and the baby doesn't look jaundiced at all, it is incredibly unlikely that that baby is going to have a high or a critical level of bilirubin. So again, if you look at a baby and they're not jaundiced, then their bilirubin is probably low. If you look at a baby and they're jaundiced, then we are awful at actually guessing what that number is. So it is helpful in that if a baby doesn't look jaundiced, you can feel pretty good about it. Key action statement 4 is that every baby in the hospital should be visually assessed for jaundice every 12 hours until discharge. If they look like they're jaundiced, then we should be sending either a serum bili or at least a transcutaneous bilirubin on that baby. Which brings us to our next point. Are transcutaneous bilirubins accurate? Well, the AAP thinks that they are a reliable and accurate screening tool to figure out which babies actually should be getting a serum bilirubin, and it's good at reducing overall blood draws. Generally, the serum bilirubin is about 3 mg per deciliter off from the transcutaneous bilirubin. It can be one way or another, but that also really depends on how much melanin the baby has in its skin. Also, at above 15 mg per deciliter, the transcutaneous bilirubin is not accurate at all after that. Fifth key action statement is that serum or transcutaneous bilirubin should be measured at least once between 24 and 48 hours of life, or before discharge. And straight onto KAS 6, and that is that a serum bilirubin should be measured if the transcutaneous bilirubin is within 3 milligrams per deciliter of phototherapy levels, or obviously if that number is above 15. KAS 7 is about the rate of rise of the bilirubin. So if you have 2 points, then you can calculate the rate of rise of the bilirubin, and it can kind of try to help you figure out whether it's rising really quickly and it's more likely to be hemolytic or not. If the rate of rise is above 0.3 mg per kg per hour in the first 24 hours, or above 0.2 mg per kg per hour after 24 hours, then this is a high rate of rise and it's more likely to be hemolytic. So just based on these 2 bilirubin points, it might be reasonable to go ahead and get the baby's blood type and the Coombs and everything. KAS 8 is if you can't get adequate follow-up for a baby that's being discharged to go get their bilirubin checked, then you should actually delay discharge. And KAS 9, in infants who are still jaundiced at 2 to 3 weeks of life, you should also measure a direct bilirubin. So if the direct bilirubin is above 1 mg per deciliter, then this is more suggestive of a liver issue. So for example, the baby could have biliary atresia, an inborn error metabolism, a UTI, sepsis, a whole list of things. Which brings us to 3, the treatment of hyperbilirubinemia, which is probably why you're all here. I won't go into a lot of details about phototherapy. Just realize that giving phototherapy chemically alters the bilirubin, so it's easier for the baby to actually excrete it. As much as the baby's body should be uncovered when you're actually giving phototherapy, and the phototherapy is basically the blue light with an average wavelength of 475 nanometers, so between 430 and 490. So realize that this is regular blue light. It's not UV light or anything, so it's not especially dangerous to babies' eyes. Babies just find it irritating. That's why we put the goggles on. The current known risk factors of phototherapy, according to the AAP, is that it slightly increases the risk of epilepsy. However, per the AAP, if phototherapy is being used to prevent an exchange transfusion, then obviously this risk is worth it. We should be measuring the irradiance level, so how much phototherapy is actually being given to a baby, on all babies that are receiving it. And the average should be about 8 to 10 microwatts per centimeter squared. That's the unit that it's measured in. When intensive phototherapy is given, we can give up to 30 microwatts per centimeter squared. They also discuss the possibility of using sunlight as a treatment to lower bilirubin levels. But they kind of go through some of the issues, and that is that we don't know how much the baby is getting. We're worried about the baby getting sunburnt and stuff. So using sunlight is not recommended where we actually have the resources to give phototherapy. And that's really what these guidelines were used for. So when do we actually start phototherapy? Well, Key Action Statement 10 shows when you start phototherapy based on figures 2 and 3 that are available to everybody. So for each bilirubin level and gestational age, you plot out the bilirubin at which hour it is and figure out whether the baby needs phototherapy or not. Figure 2 is for when there are no neurotoxicity risk factors, and then you can see there are lines for different gestational ages. And again, this is for gestational age at birth, and it's also dependent on the time the bili was checked. Again, this is the total serum bilirubin, not transcutaneous bilirubin, and you don't subtract the direct bilirubin. So let's say you have a 39-week infant who is 24 hours old with a bilirubin of 9. Do we start phototherapy? So let's plot that out. Officially not starting phototherapy at that level. Figure 3 is for when there is at least one neurotoxicity risk factor. So apart from gestational age. So again, gestational age less than 38 weeks, albumin less than 3, sepsis, hemolysis, or being critical in at least 24 hours. Note that infants above 38 weeks are all grouped together here. Basically, all these thresholds have increased slightly from the previous normograms that were released by the AAP, probably about 2 milligrams per deciliter higher. So we are starting less phototherapy now than we were a few years ago. The AAP also notes that it would be acceptable to start phototherapy at a slightly lower level just if the baby's about to go home, just to make sure that the baby doesn't have to get readmitted. KAS 11 though is that if a baby does go home and ends up needing phototherapy, then home phototherapy can be done as long as the baby doesn't have any neurotoxic risk factors. I'm not going to go over this more because it's kind of outside the realm of the NICU. The importance of feeds are also emphasized, and we all need to make sure that these babies are feeding very well. You can stop the phototherapy while the baby is being breastfed. So remember, phototherapy kind of starts an enzymatic reaction, so the baby doesn't have to be continuously under the phototherapy for it to work, but the more time the better. IV fluids should only be used if the baby is actually dehydrated, so it's like breastfeeding jaundice and your sodium's 152 or whatever, or if you're actually escalating care, so you're getting closer and closer to need an exchange transfusion, then yes, you should be starting IV fluid. 12, bilirubin should be checked once you've started a baby on the phototherapy at a maximum of 12 hours after starting the phototherapy. If the baby's bilirubin is high or there's a rapid rate of rise, then you should be checking the bilirubin levels before that. And again, it should only be the serum bilirubin that you're checking when a baby is under phototherapy. When you put them under the phototherapy, the transcutaneous bilirubin is the one that's going to go down the first. So once you're under phototherapy, transcutaneous bilirubins are not accurate. So it needs to be a serum bilirubin. KAS 13, I'm including this so you don't wonder where number 13 is. Babies who are on home phototherapy have to have their bilirubins leveled at least every 24 hours. Remember, those are babies without neurotoxic risk factors. KAS 14 is important clinically. What should you be checking if a baby is placed under phototherapy? Well, the AAP recommends at least a hematocrit or a CBC, checking to see if the baby is anemic. If you're worried about hemolysis, you can also check a reticulocyte count. They don't mention that, but I'm just adding that. Obviously, you should be checking the baby's blood type if the mother is O or she had a positive antibody screen. And then really, you should be trying to figure out what is actually causing the baby's jaundice. And should you be worried about hemolysis? Should you be considering G6PD? So depending on what the cause is, then you're more likely to be more or less aggressive. KAS 15 is when you stop the phototherapy. So you can stop the phototherapy when it's at least 2 mg per deciliter below the threshold level for phototherapy for that age. If the baby has additional risk factors, so for example, the hyperbilirubinemia is hemolytic, or phototherapy was started when the baby was less than 48 hours old, then you can wait for that bilirubin level to get further away from the phototherapy level, so 3 or 4 or whatever else you choose. Let's go on to KAS 16. When do you get a rebound bilirubin? So to make sure that it hasn't shot up after you've stopped phototherapy. So the AAP recommends that you get, oh my glasses. So the AAP recommends that you get a follow-up bilirubin between 12 and 24 hours after stopping phototherapy. And if it's hemolytic, then you can get a bilirubin earlier than that, so 6 to 12 hours after stopping phototherapy. Remember, if the baby's been under phototherapy, then you have to get a serum bilirubin to check the rebound. If you're checking a rebound bilirubin beyond 24 hours after the phototherapy is stopped, then you can check a transcutaneous bilirubin, because after 24 hours, kind of all the bilirubin has equilibrated again. Now let's talk about escalation of care, which is basically anything that you do beyond phototherapy to prevent an exchange transfusion. Again, we've spoken about exchange transfusions as well, so go back and look at that video if you want to know anything more about that. An algorithm is in place for what should occur when you are escalating care. And basically, escalation of care should happen when you are 2 milligrams per deciliters or less away from the exchange transfusion levels. And we'll cover the exchange transfusion level graphs in a second. KAS 17 refers to the figures that you have to look at to determine whether a baby needs an exchange transfusion or not. So they're just like the phototherapy graphs, but these are all obviously a little bit higher, the numbers, because they're the levels that you actually have to do an exchange transfusion. Again, there's one graph for babies without neurotoxicity risk factors and one graph for babies with neurotoxicity risk factors. So altogether, there's 4 graphs that you should be aware of. 2 graphs for the phototherapy levels and 2 graphs for the exchange transfusion levels. So again, when you are looking at the graphs, you plot out the age-specific serum bilirubin level, so the hours that the bilirubin was checked at, on the right gestational age for the baby, and then you see where it plots out. If you're within 2 milligrams per deciliter of the exchange transfusion level, then you need to escalate care. Probably the most important aspect of escalation of care is making sure that the baby is somewhere where an exchange transfusion could be done. So if the baby is still on the floor with their mothers, then they need to be transferred to the NICU. If you're in a hospital where you can't do an exchange transfusion, then you need to send that baby somewhere where they can. There are 3 key action statements covering the escalation of care. So 18, KAS 18, is that for any babies that are having escalation of care, then you should immediately send a stat, serum bili and a direct bili, a CBC, an albumin level, chemistries like checking if the baby's dehydrated or anything, as well as a type and cross match, because if you end up giving blood, obviously we need to have that blood ready. KAS 19, infants needing escalation of care need intensive phototherapy, so check the irradiance, it needs to be closer to that 30 microwatts per centimeter squared number. So intensive phototherapy as well as IV hydration. And there should be a neonatologist on board, so to admit the baby to the NICU. KAS 20 is that the serum bilirubin level, when in infants who are requiring escalation of care, the serum bilirubin level should be measured every 2 hours until you are no longer in the zone of escalation of care. So until you're at least 2 or 3 or 4 away from needing the exchange transfusion. KAS 21 is that IVIG or IV immunoglobulin can be given to babies with the isoimmune hemolytic type of jaundice. So obviously the babies that are Coombs positive. And we made a whole video about this, so if you want to know more, then go back and watch these videos. Generally, we can give between 0.5 and 1 gram per kilo. Honestly, by the time I'm giving IVIG, I pretty much always give the 1 gram per kilo, and it needs to be given over 2 hours. If you do need to repeat this, then you can repeat this dose 12 hours later. And then this is figure 4, which beautifully delineates what you're doing for the babies when you're escalating care. And again, you can see it starts very clearly with make sure that you are somewhere where an exchange transfusion can be done. KAS 22 is that an urgent exchange transfusion should be performed in babies with high bilirubin levels, even if they're not quite at the exchange transfusion level, and any signs of acute bilirubin encephalopathy. So things like hypertonia, so the baby's a lot stiffer. Remember, normally when bilirubin levels are a little bit elevated, like the high teens, normally babies are a lot sleepier and more tired and less likely to eat as much. If they're really going into the hyperbilirubin encephalopathy stage, then they can become really stiff and they can have retrocollis, so their neck is backwards. They can have arching, also opisthotonus, I think that's how you pronounce it. And that's a really bad stage where it's kind of what you can see in adults with meningitis or something, where their whole backs and necks are kind of arching and very stiff going backwards. Other signs of bilirubin encephalopathy are a really high-pitched cry and also the baby developing apneas, like true central apnea. And KAS 23 is that an urgent exchange transfusion should be performed once you actually reach the threshold levels for the exchange transfusion, depending on which graph you're following. So as you all know, it can take about 4 hours at least for the blood to be set up, getting it ready for the exchange transfusion. So while you're waiting for that, you should be checking the bilirubin every 2 hours. If the bilirubin level ends up coming down below the exchange transfusion level, even if the blood is getting ready, then you can hold off actually doing the exchange transfusion. Just as a reminder, we do the exchange transfusion by taking out obviously the baby's whole blood and putting back in red blood cells reconstituted with FFP, or basically with fresh frozen plasma, all the good proteins that are in blood. So normally the blood bank has to take red blood cells and then take FFP and make the hematocrit of the blood that we're giving about 45%. So the blood that we're giving doesn't have white blood cells or platelets. If you want to know more about this, go look at the exchange transfusion video. The AAP also mentions that you can use the bilirubin divided by the albumin ratio to decide whether you do want to go forward with an exchange transfusion or not. I've actually never used this number trying to make that decision or not, but they lay it out very well, the numbers that you accept depending on the risk factors for the baby. So the ratio levels are anywhere between 6.8 to 8 bilirubin over albumin. Now let's cover 4, the post-discharge follow-up. And honestly, I think this could be my favorite part of this entire paper. Because previously, when we were sending babies home from the hospital and they had to follow up with their pediatricians or whatever, we just kind of went on a hunch when the babies should be followed up to check their bilirubin again. But in this updated policy statement from 2022, they cover exactly when the baby needs to be followed up. And when the baby needs to be followed up is dependent from what their discharge bilirubin is, or the bilirubin closest to discharge, and how far away that bilirubin is from the phototherapy level. So KAS 24 is exactly that the follow-up that the baby needs will be determined by the last bilirubin that was checked before the baby went home. So as you can see from this beautiful figure 7, if the bili at discharge or right before discharge is, for example, 4 away from light level, then the baby needs to follow up in 1 to 2 days. Obviously, there are caveats here that you may want to follow up sooner than that or later than that, depending on, for example, if the baby's breastfeeding or if the baby's already lost a little bit of weight, then obviously you'd want to follow up a little bit sooner than that. Also, we need to have policies in place for how these babies follow up. And that includes when we send babies home on weekends or on holidays. I always think that the Wednesday before Thanksgiving is absolutely the worst, because Thanksgiving, for all you non-Americans, falls on a Thursday always. And so if you're sending a baby home on the Wednesday, nobody works on Friday of Thanksgiving, Black Friday. So Thursday, Friday, Saturday, Sunday. So it's really tough sending babies home on the Wednesday before Thanksgiving. And the last KAS, Key Action Statement, so Key Action Statement 25, is that all families being discharged from the hospital should receive verbal and written information about jaundice and the risks of kernicterus, and they should also have the last bilirubin level that was checked on their baby and a good plan for follow-up. Okay, I hope that helped you all clinically going through that paper. I can do that more often if you're all interested in it, if there's kind of like a big policy statement or something like that that comes out. In the meantime, can you tell me where you're watching from? Like this video, and again, I really just want to tell you thank you so much for being here.